Okay, so welcome everybody to Thyroid Day. Congratulations for getting through Hypothalamus and Pituitary Day. We were all very impressed by every single small group for Hypothalamus and Pituitary Day, so don't tell the class before you, but we were markedly impressed. Kudos to you. Congratulations. Let's see how you do on Thyroid Day. Today we're going to have two lectures. The first one's going to be a discussion of thyroid physiology, and the second half of this first talk is going to be about the disease called hypothyroidism. The second talk is going to be about an overactive thyroid, thyrotoxicosis, and the second half of that talk, or sort of last quarter of that talk, will be dedicated to thyroid nodules and thyroid cancer. Just a public service announcement. I was listening to NPR this morning, and as someone who cooks a lot of chicken, learned, and I had been told this before, that you're actually not supposed to wash your chicken because you spray salmonella and all the other bad stuff all around the kitchen. Like 3-6 feet away, they'll actually find salmonella if you wash salmonella in your kitchen, if you wash your chicken in your kitchen sink. So I thought I had to spread the gospel. I know my parents wouldn't believe me when I tell them that, as I will next week, but you might want to spread that word or just take over the cooking yourself and not wash your chicken, because you're doing a lot of disservice to your own kitchen should you wash your chicken. So that's my public service announcement for this first lecture, and then I have an interesting question to see if anybody knows the answer to for the second lecture, and that's my teaser to try and get you to stay for the second lecture. Okay, so we're going to talk about thyroid physiology. By the end of the next half hour, you will actually have an excellent understanding of the way this entire system works. We learned a lot about the hypothalamus and TRH stimulation to the anterior pituitary, which releases TSH. Today we're going to spend a lot of time on what actually happens inside the thyroid. And we're going to learn about the two hormones that are secreted from the thyroid, thyroxine and T3. And we will also gain some understanding about thyroid binding proteins and how thyroxine is bound and in very small concentrations free in the systemic circulation, and it's the free concentration that we actually care about and what governs physiologic activity. Okay? But first, where is the thyroid? Okay? So the thyroid actually sits right above your sternal notch. Doing the exam for the thyroid is critically important. Whenever you are presenting a case and you begin to talk about the thyroid, your preceptor, attending, the endocrinologist is going to want to know a pretty significant amount of information about what you found on exam. In fact, I'm going to convince you in the second talk that with your exam skills alone, you're going to be able to diagnose the most common cause of hyperthyroidism, usually more often than not, and you won't have to do any fancy or elaborate testing. So how do you actually examine the thyroid? Well, the first thing that you do is you put your index fingers. Usually you have the patient sitting down and you're standing behind them. You take your index and middle finger and you roll it over to where you feel the cricoid cartilage. And then you begin to move your fingers down the neck and a little bit lateral, and that's where you will feel sometimes the soft normal tissue of the thyroid. Sometimes it's firm, sometimes you feel a lump. You start to move your fingers a little laterally. If you're still not able to feel anything, you can kind of extend the space between your second and third finger and ask the patient to swallow. And usually at the swallowing time, you'll feel something roll up to your fingers. And that's actually the thyroid. And when you're describing it, you want to say whether or not you feel it sort of symmetric on both sides, whether or not you feel one lump on one side and not so much of anything on the other, whether you feel a lot of lumps on both sides, whether or not it feels very firm or very soft. It takes a lot of experience to do the thyroid exam well, and I would, as I said before, this is the kind of stuff we do at parties. If you get together with endocrinologists, we'll all be everybody sitting down, standing up, sitting down, standing up, feeling each other's thyroid glands. It's something that you should get familiar with, feeling your colleagues' thyroid glands or your family's thyroid glands, your pet's thyroid glands. It's all in the same spot. But the critical thing is to use your fingers to first find the cricoid cartilage and then walk down and move a little bit laterally, and that's where the thyroid is. We also do auscultate the thyroid, so we listen with our stethoscope, trying to hear if there's any increased blood flow, and we'll go over that in the next talk. Okay? So thyroid is located in the anterior and inferior part of the neck, right above the sternal notch, and the landmark for your exam is the cricoid cartilage. If you took the thyroid and went down to the cellular level, it's a very interesting gland. What you see here is what we call a thyroid follicle. And a thyroid follicle are these thyroid epithelial cells, or follicular cells, with their nucleus. The basolateral membrane's here, and the apical membrane is here. And inside, or central to the thyroid follicle, is what is called colloid. And colloid is a storage area for thyroid hormone. And I'll show you specifically what gets stored in there. But unlike many other glands in the body, the thyroid actually stores thyroid hormone so that there's an ample supply of it should you need it. There are also cells that are not thyroid follicular cells. We call them parafollicular cells, or C cells. And they secrete calcitonin, which has to do with bone metabolism and is not related to actual thyroid function. May not even have a role in human physiology. Is not regulated by TSH the way that thyroid follicular cells are, but is very important because these are the cells that generate a type of thyroid cancer called medullary thyroid cancer, and you're going to hear a lot more about that, specifically when we talk about endocrine neoplasia, because we use the product of these cells as a means by which to see if somebody has or doesn't have disease. So if we take the thyroid and we cut it and we look at it on slides, this is what we expect to see: a collection of epithelial cells in a follicular unit with colloid central to that, and that's where your stored thyroid hormone lies. But if we looked at a specific thyroid follicular cell itself, or one or two of them next to each other, this is how I want you to think about what is going on within the thyroid. And the thyroid is actually one of those organs where the diseases, if you remember the physiology, you can understand how we use blood tests, imaging tests, to figure out exactly what's going on with a person's disease. So you really do have to remember the underlying physiology to understand how to diagnose and work up diseases of the thyroid gland. So here is the thyroid follicular cells. I have circled the critical mediaries of thyroid hormone production. Okay, you have the TSH receptor, okay, which we know binds TSH and activates actually pretty much all of the steps of thyroid hormone synthesis, storage, and release. Okay, so that's our critical hormone receptor interaction. There is a sodium iodide symporter that sits at the basolateral surface of the cell. It is under TSH stimulation, or TSH regulation. There is the thyroid peroxidase antibody. This is the enzyme, thyroid peroxidase enzyme. There's an antibody to it. We'll talk about that later. But this is the enzyme that is sort of the workhorse. It's not entirely understood exactly how it does the things that it does, but it basically takes the iodine and allows for the production of thyroid hormone. So it's a critical enzyme. And there's thyroglobulin, which is a very large protein that is stored in the colloid and actually has thyroid hormone bound to it. And that's what gets pulled back in. You can see these arrows here. When the body needs to release thyroid hormone, there's an endocytosis process that pulls in thyroglobulin, removes the thyroid hormone, and allows for thyroid hormone secretion. And all of that, as I'll continue to say, is under the regulation of TSH. And as you get more familiar with my lecture style, you'll learn that as I continue to repeat things, I'm repeating them because of the critical nature of that interaction. Okay? So you will have a great understanding of this, but let's dive in and start with the sodium iodide symporter. So thyroid hormone requires iodide. So much so, actually, that the sodium iodide symporter actively transports iodide across a concentration gradient, and intrathyroidal concentrations of iodide are markedly higher than serum levels of iodide. So it uses ATP to do this. It's under stimulation of TSH, and this is the first step in actually producing thyroid hormone, and we can refer to this as iodide trapping. So iodine has to come in across a concentration gradient from where it is low in the circulation to where it is high, and then get trapped inside the thyroid follicular cell so it can actually iodinate tyrosine residues on thyroglobulin, and that's the precursor for making thyroid hormone. Now, normal iodine uptake is about 10 to 30% of what you take in a day. There's not a lot of iodine deficiency in the United States because we iodinate the salt that the vast majority of us use or find in our food supply. But that was very critical because goiter, or an enlargement of the thyroid, and hypothyroidism were not uncommon problems until it was realized that ingestion of iodine in areas where iodine deficiency can actually reduce the goiter and cure the hypothyroidism. So iodine is actually found in our salt supply. So it is not a common cause of hypothyroidism here in the United States. But in areas where iodine is in short supply, it's one of the more common causes of hypothyroidism and goiter. And those are usually inland areas where the diet is not based in sort of seafood or fish or food that is high in iodine. Now, there's a couple of regulation steps you need to know about iodide trapping. The first one is that if you do have iodine deficiency, the sodium iodine symporter accelerates its ability to take in iodide, and the thyroid follicular cells accelerate their ability to trap it, so that you really use all of that iodide to make thyroid hormone because of the critical nature of thyroid hormone. And I'll show you in a few slides what thyroid hormone does. But first we need to know how it's made. The flip side is that if there is all of a sudden a high concentration of iodide that is seen by the thyroid follicular cells, the symporter can shut down. And organification of iodine into thyroglobulin can also be turned off. And iodine also can actually decrease the release of thyroid hormone. So if there's a sudden surge of iodine that comes into the body, these processes are decreased so that the iodine is not used to generate an overabundance of thyroid hormone. And this is called the Wolff-Chaikoff effect. It lasts for about a week or two, but then there's an escape phenomenon that can occur, and the cell can go back to trapping iodine again. But we actually use this to treat certain conditions, and I'll get into that when we talk about overactive thyroid. Just so you know, the sodium iodine symporter is not specific to the thyroid gland, but the thyroid gland is the only organ in the body that traps iodine and makes thyroid hormone. You can find the symporter in these different glands here. Just a quick word on pendrin, or apical iodine transfer protein. So the iodine in the basolateral surface is actually the pendrin molecule brings iodine up to the apical surface where thyroid peroxidase can do its activity. And there's a disease of deafness and goiter that's associated with deficiencies or mutations, actually, in the pendrin molecule. And again, this system in the sodium iodine symporter is exquisitely regulated by TSH. So we now know that iodine is trapped in the thyroid cell. It's brought in by the sodium iodine symporter across a concentration gradient. The next steps that occur in the production of thyroid hormone are oxidation, where the TPO enzyme and hydrogen peroxide actually oxidize the iodide molecule. And this is all happening up here at the apical surface. And then very quickly, the organification process occurs. And organification means that the iodine is actually placed on a tyrosine residue that sits on the molecule thyroglobulin. And as you can see here, there's two different forms of iodinated tyrosine. There's MIT, where a single iodine, and I'll show you what it looks like on the next slide. A single iodine is placed on the tyrosine backbone. And there's DIT, where you have a doubly iodinated tyrosyl residue on thyroglobulin. And that's MIT and DIT. So iodine is transported in, oxidized, and quickly organified to MIT and DIT, which are on the thyroglobulin molecule that sits now in the colloid. And then there's something called the coupling process. And the coupling process is where MIT and DIT are coupled together to generate either thyroxine or T4 or thyrine T3. And that all happens, again, under the direction of the TPO enzyme here in the colloid. And that's the actual generation of thyroid hormone. More T4 is generated in the thyroid than T3, but we'll talk about that in a couple of slides. And again, this system is exquisitely regulated by TSH and TSH receptor interaction. So more schematics. Here's thyroglobulin with its tyrosine residues. Okay, a single iodinated tyrosine residue generates MIT. Doubly iodinated tyrosine residue is DIT. Now, I mentioned many times that endocrinologists were not very good at naming diseases. We unfortunately make things a little confusing. But math is not one of those things we make confusing. So the coupling reaction is pretty simple. If you have a doubly and a singly, 2 plus 1 is 3. That generates T3. If you have two doubles, 2 plus 2 is 4, and that generates thyroxine. Okay? What about thyroid hormone release into the circulation? So what happens is when there is a signal that we need more thyroid hormone for the systemic circulation, obviously TSH is released, binds to its TSH receptor. All of the previous steps are undertaken. And then there's endocytosis. So part of the colloid is actually pinched off, and thyroglobulin, with its some MIT and DIT still left on it, a little bit of T3 and a large amount of T4, are pulled in by endocytosis. It interacts with a lysosome to generate a phagolysosome, and then proteolysis occurs, and two things happen. The less important, but still you need to know it, interaction is that MIT and DIT, because of the scarcity of iodine evolutionarily, and before it we iodinated the salt, are actually broken down by a process called dehalogenation, and the iodine is then brought back to the apical surface to be used to generate more thyroid hormone. Not a lot of iodine, after it's trapped in a thyroid follicular cell, is going to leak back out. It's very much conserved. The more important thing is that the lysosome breaks T3 and T4 off of the thyroglobulin backbone and releases it into the systemic circulation. And that, again, is all regulated by TSH's interaction with the TSH receptor. Now, once these dipeptides are in the circulation, remember that they are a little bit of a sort of counter to the rule. They're peptide hormones, but they require binding proteins. And so there's 3 binding proteins that can bind T4 and T3. And you see them here. So there's thyroxine-binding globulin, which is the main player. There's transthyretin, and then there's albumin. So TBG carries roughly 70 to 80% of bound hormone. TBG is synthesized in the liver. The rest is somewhat split between transthyretin and albumin. Albumin doesn't have a very high affinity for thyroxine, but there's so much albumin around that it can bind upwards of, say, 10 or 15% of the thyroxine in the circulation. Now, how much is actually bound? The vast majority of thyroid hormone is bound. So for T4, it's somewhere around 99.96 to 99.98% is in the bound state, leaving a very small but critically important amount of hormone free in the circulation. It's the free hormone that diffuses across the cell membrane into the cytoplasm, where an enzyme will take T4 and turn it into T3, which is the more active hormone. T3 will then go into the nucleus of the cell, remove repressors, and move forward transcription and translation. So the free proportion is exquisitely regulated, and that's what promotes negative feedback to the hypothalamus and pituitary. So anything that may alter TBG, or thyroxine-binding globulin, could have an effect on the free amount of hormone in the circulation, but that will quickly feed back to the hypothalamus and pituitary and re-equilibrate the amount of free hormone that's in the circulation. So as an example, There are things that increase thyroxine-binding globulin. There's high estrogen states like pregnancy or oral contraceptives, acute hepatitis. There are certain drugs that can do this. I believe heroin is actually one of those drugs, oddly enough. And there are inherited disorders where you can have an increase in TBG. There are also things that can decrease TBG. So as opposed to estrogens affect androgens, can decrease thyroxine-binding globulin. High doses of glucocorticoids. Any syndrome that you may have learned about in renal physiology where you have a low amount of albumin and a low amount of proteins because they keep getting spilled out into the urine. Someone can call it out. Right, nephrotic syndrome, exactly. So nephrotic syndrome, you're wasting proteins. TBG levels can go down. Cirrhosis, you don't generate the proteins. And there's inherited disorders of TBG. The important concept here, though, is that although there may be alterations, it's the free level of thyroxine that we are most interested in, even though it's hard to measure. And so things that alter TBG in one direction or the other, they would have an effect on the total amount of thyroxine that you measure. But we're more interested in measuring the free level of thyroxine in the blood, not necessarily the total. So during pregnancy, estrogen levels go up. And if you measure total levels of thyroxine, total T4, you'll see very high levels, usually 1.5 or 2-fold above the upper limit of normal, but a completely normal TSH. If you measured free T4 at the same time, you would usually see that free T4 is in the normal range. So this is an expected rise in TBG that affects the blood tests, and physiologically you need to be aware of it. But because we try and measure free T4 and not total T4 whenever possible, these don't have necessarily a role in causing thyroid hormone excess or deficiency. There's an interesting inherited disorder called familial dysalbuminic hyperthyroxinemia, where albumin has a higher affinity for binding T4. And again, it's a condition where if you measure total T4, you would see a rise in total T4. But if you measure TSH, it would be normal. And if you looked at the free concentrations of thyroxine, they too would be normal. Because it just has to do with a binding affinity, but it doesn't actually have a role in causing pathophysiology. So that's the binding proteins that carry thyroxine and T3 through the serum. This is sort of a schematic. It's not the easiest one to understand. But what it's trying to say is that the vast majority of hormone that's produced by the thyroid is T4. T4, as we're going to learn in a slide or two, has a much lower affinity for the thyroxine receptor, which is a nuclear receptor, than T3. So T4 is converted peripherally to T3, and it's the local T3 that usually will activate the nuclear receptors in the periphery. But the vast majority of hormone that comes from the thyroid gland itself is T4, usually a roughly speaking 10-to-1 ratio. So that's why you see that this is shaded here, because all T4 comes only from the thyroid. T3 comes a little bit from the thyroid, but the vast majority of it is made by deiodinase enzymes, enzymes that remove an iodine molecule from T4. And then T3 binds to the nuclear receptor and does its activity. Thyroxine, which is exquisitely bound to thyroxine-binding globulin, has a very long half-life. If your thyroid was removed today, you still have a few weeks left of circulating thyroxine concentrations. 100% produced in the thyroid. T3, on the other hand, has a bit of a shorter half-life, roughly speaking about a day. And only about 20% of it is actually made in the thyroid. There's also reverse T3, which is an inert molecule. Okay, it doesn't have activity. It's a way to clear thyroxine from the circulation. Diseases of critical illness, instead of making thyroxine in the periphery and activating skeletal muscle, which may not be the most important thing if you're suffering from, say, septic shock or some other internal insult, more RT3 or reverse T3 is generated than active T3, and it's a way of conserving thyroid hormone for sort of the critical internal or central processes. We see this a lot in the hospital in hospitalized patients. It's called non-thyroidal illness or euthyroid sick syndrome, where T4 is sort of shunted towards reverse T3 rather than active T3. And it makes interpreting thyroid function tests in the hospital quite difficult. But usually it's just a physiologic correction that the body is doing to conserve, and it's not necessarily associated with pathophysiology in and of itself. In other words, it doesn't mean that the thyroid is a problem. It just means that the thyroid may be responding to another problem. So here are the, just to let you know, if you were on the website yesterday and downloaded the slides, this is the first one you're going to see where there's a change from yesterday. Okay, because I picked up on something that was not correct at like 11:30 at night. Kudos for me. Mostly because Dr. Sirks is sitting in the back of the room, and he has been my mentor for thyroid disease. He has built an entire career around basically elaborating these mechanisms and understanding these diseases. And so I had to make sure I didn't say anything incorrect, because he's probably going to activate his eMed account and listen to every word I have to say to review to make sure I get it correct and then remind me where I may have had a misspeak. So I will let you know if I did have a misspeak. But I picked up on this error last night. So this is the deiodinase pathway. And thyroxine, if it is activated by type 1 or type 2 deiodinases, these are 5' deiodinases. Here's 5' here. Notice that the iodine is then removed. So the somewhat inert T4 or precursor molecule T4 is then activated to T3. And this is the active hormone that can bind the nuclear receptor and remove co-repressors, induce activators, and sort of unleash the process of transcription and translation. T4 can also go down another pathway where it's the 5-deiodinase, the 5-position iodine here, that can be deiodinated, and that makes the reverse T3 or inert T3. And that's the process that happens when you're suffering from a critical illness unrelated. So here's a bit of a schematic. I don't want, this is, if you look at different sources in the literature, you'll find different answers to where these two different deiodinase enzymes may be. I want to keep it very simple for you. The type 2 deiodinase is the one that we would find in the pituitary gland that governs negative feedback. That's a very important one. The type 1 deiodinase, although you will also see type 2 in the periphery, the type 1 you can think of more as generating peripheral thyroid hormone for thyroid hormone function in the periphery. And different levels of thyroxine, hyperthyroidism, and hypothyroidism can affect the activity of these enzymes. Type 1 is sensitive to a drug we use to treat an overactive thyroid, which is nice. If we can give a drug that would decrease the conversion of T4 to T3, keep most of the hormone in the T4 state. But I don't want you to spend a lot of time on this slide. In fact, I blocked it out sort of purposefully because it can get quite confusing. So what's actually happening down in the nucleus of the cell? So there are two thyroid hormone receptors. There's an alpha, which is generally found in these tissues here, and a beta, which is found in the pituitary and liver. When thyroxine is not present, there are co-repressors that actually suppress transcription and translation of thyroid-responsive genes. When T3 is generated in the cytoplasm and goes into the nucleus and binds to the T3 receptor, those co-repressors are removed, and inducers and activators of transcription and translation are allowed to move forward, and that's actually what generates the thyroid's function. So this is what's happening in peripheral tissue, where there are thyroid hormone receptors. There's a very, and again, there's a much higher affinity for the thyroid receptor for T3 than T4, which is what makes T3 the active hormone and T4 relatively inactive. The beta receptors can be the source of a form of what's called resistance to thyroid hormone. So you can imagine that if the beta receptor couldn't sense thyroid hormone activity, that there would be negative feedback, and there would be an upregulation of TSH to generate more thyroxine. And that's basically what happens is you shift set points a little bit to the right. You need more thyroid hormone to do the usual activities of thyroid function. The resistance is not generally associated with disease, although there can be, specifically if there's preferential more resistance in one area than the other. But it is something we need to be thinking about when we look at abnormal labs, because we would see a higher level of T4 and T3 in the periphery associated with a normal TSH or even a high TSH. So it's a little bit opposite of what we talked about in the inappropriately normal state for underactive disease when it's central. This has to do with the actual beta receptor being insensitive to thyroid hormone. So I basically put this here because you should now be able to walk yourself through hypothalamus generating TRH to the pituitary, which generates TSH, which goes to the thyroid and generates majority of T4, which then travels in the circulation bound to binding proteins, is activated upon by the 5' deiodinase, which makes T3, which binds its nuclear receptors and has its peripheral effects. That also happens to go back and induce negative feedback. And the type 2 deiodinase enzyme is the one that's a little bit more associated with pituitary activity and negative feedback there. Good. We're all on the same page? Excellent. Study this for a while. But I'm going to keep going back to something like this to continue to drive home the point that thyroid physiology really does allow us to think and be able to make the diagnosis of overactive or underactive syndromes. So what does thyroid hormone do? Lots of things. It's sort of a gatekeeper hormone, in a sense. It allows for fetal brain development. You're going to learn in growth and development how important thyroid hormone is in fetal development. It governs your basal metabolism. In the heart, it is a positive inotrope and chronotrope. It also enhances sensitivity to adrenergic activity. In the sympathetic nervous system, it increases beta-adrenergic receptors and it enhances sensitivity to catecholamines. It allows for permissive responsive to low oxygen states and high CO2 states. It is important in hematopoiesis, in gut motility, in skeletal rearrangement of bone. It actually promotes bone turnover and more resorption, or the breakdown of bone, than formation. We'll get into why hyperthyroidism can cause osteoporosis. Neuromuscular, it's important for muscle contraction and relaxation. It's important for fuel metabolism. And basically, the production, responsiveness, and metabolic clearance of many of the hormones that we talk about are all regulated by thyroid hormone. So you learned about this last week, and now you've actually learned about this. So let's go over a few tests that we use, and then I'll bring you down into the world of hypothyroidism, and we could start thinking about disease states. So there, as I've already tried to enlist you to my side, whenever you start ordering hormone tests, you should order them in pairs. You should order the central hormone and the effector hormone. TSH is the master test. It's very sensitive. It's very important, but by itself cannot entirely or always be an accurate descriptor of what's actually happening with thyroid hormone production. Now, there's total T4 that we could measure, but that's binding protein dependent, as I showed you. And there are states where thyroid binding proteins can go up or down, and they actually don't affect or don't have any pathophysiology associated with them. So we try and stay away from that. Free T4 is the unbound portion of thyroxine, and because all T4 comes from the thyroid gland, it's the best test to tell you what's actually happening inside the thyroid. T3 is not so useful. One, it's very hard to measure free T3, but two, it's peripherally produced. So you have to, all of the physiology that allows T3 to get to the systemic circulation and then get activated upon means that there's a lot of peripheral production of T3. So it's not always a useful test to do. So the two important tests when we're measuring thyroid function are free T4 and TSH. We also have tests of autoimmunity, because in the United States, the most common cause of an underactive thyroid gland is actually an autoimmune disease called Hashimoto's. And TPO is best thought of as a general marker for any thyroid autoimmune problem. It's not specific for any one thyroid-related problem, but it's a general marker that there may be something autoimmune going on regarding the thyroid. Thyroglobulin antibody is somewhat similar to TPO. It's just less commonly positive, so we don't measure it that often. The TSI we'll talk about in the next lecture. That's an exquisitely specific antibody that activates the TSH receptor. So here's our blood tests that we order, free T4 and TSH, tests of thyroid autoimmunity. And then we can do anatomical thyroid tests. We can do an ultrasound, which allows us to see what the gland looks like. Or we can do a functional test, usually reserved for hyperthyroidism, called an uptake and scan. So anatomical imaging looks like this. This is normal thyroid tissue here. This is just an ultrasound probe. Someone's lying down, sitting right on the thyroid. Here's the trachea. Here's the isthmus of the thyroid, and you see this lump. That shouldn't be there. The lump has blood flow in it. That's not good. If we get concerned about something like this, we could take a needle and stick it in and pull out some cells, send it down to a pathologist to look at. We'll talk a little bit about that in the next lecture. Now here's an uptake test and a scan associated with it, and this is important to understand. We can utilize the fact that iodine is preferentially trapped by the thyroid gland in order to make a diagnosis of an overactive thyroid. And sometimes it helps us even with types of underactive thyroid, but that's much less common. So if we send into the body radiolabeled iodine that gets taken up by the thyroid gland and trapped there, we should be able to tell if we give a certain dose of iodine how much iodine gets trapped in the gland, which is what we call the uptake. And then if there's iodine trapping, we then take a picture of the gland and we can see either normal, this is the right lobe and the left lobe, this is relatively normal, or we could see these really hot spots that are really intensely trapping iodine. And we'll talk about what this means. But this is actually something called the toxic multinodular goiter. So those are the tests that we use. We have our blood tests, we have our antibodies, we have our anatomical imaging, and we have our functional testing. So let's talk about hypothyroidism, because we're done with the physiology part of the talk today. So hypothyroidism is basically a clinical condition of a lack of thyroid hormone or thyroid hormone deficiency. You can have two reasons for this. There's the primary reason where the problem is in the thyroid gland itself, or you can have a secondary reason where the problem is either in the hypothalamus or the pituitary. It's very much the same diseases that we talked about last week that can cause panhypopituitarism are the things that can cause central hypothyroidism. We're going to focus today mostly on the primary causes, the most common of which is where the body's immune system basically looks at the thyroid as if it was foreign and begins an attack on it. And that's called Hashimoto's thyroid disease. Now, of course, if you have surgery to have your thyroid removed or you have iodine therapy to destroy your thyroid, that would cause an underactive thyroid. Iodine deficiency is not very common here, but it is worldwide. There are infiltrative diseases that can move their way into the thyroid, but it's very rare. Sarcoidosis, which you learned about, can do it, but it's rare. You could have external radiation to the chest or the neck for something like a lymphoma, and that could destroy the thyroid. You could have what we could label as inability to repair the thyroid gland after a thyroiditis. A thyroiditis is, we're going to learn in the next lecture, is sort of a destructive process that happens in the thyroid where the cells start leaking out all of that stored hormone. And because they leak out that stored hormone first, you get this hyperthyroid phase, but that sort of heals itself and the gland repairs itself, usually back to normal, but sometimes the gland can't. And when it can't, that can be a cause of permanent hypothyroidism. There are medications, amiodarone, which is used in the cardiac world for things like atrial fibrillation and other arrhythmias, lithium, which is a psychiatric medication. And there's also problems with iodine trapping or thyroid hormone production that are congenital. And so congenital hypothyroidism is common enough that all children are screened for it as newborns. Typically because thyroid hormone plays such a critical role in development that you want to find out if some child is thyroid deficient or not as soon as you can so that you can begin replacement. So I hate to go through this, but I have to do it just one more time. Primary hypothyroidism is a deficit here in the thyroid gland itself. And yes, I know. I don't want to do it, but I have to. And when the thyroid gland is destroyed, remember, the initial response is that there's going to be no production of thyroid hormone, and that is going to feed back on the hypothalamus and pituitary, which is going to upregulate TRH and upregulate TSH, and you're going to see the pattern we associate with primary hormone deficiencies: low T4, high TSH. as opposed to what would happen when we saw this last week, and that is there's a problem in the hypothalamus or pituitary, and the initial problem is a drop in TRH and TSH with a subsequent drop in T4. And so you see a low level of thyroid hormone with a low TSH, or, say it with me now, normal level of TSH, which we consider to be inappropriately normal, and that is why we do not use TSH by itself as a screening test. So here is a picture, rather than a drawn picture. These are thyroid follicular cells. Here is the colloid here. It usually stains pink when we see it on pathology slides. And this is what a normal thyroid gland looks like, right? Normal thyroid architecture. Lots of these thyroid follicles generating and storing thyroid hormone. Here is what Hashimoto's looks like. Hashimoto's is the most common cause of hypothyroidism, primary hypothyroidism in the United States. And you see here, this is a lymphocytic infiltrate. If you remember what a lymph node looked like from histology, germinal centers, this is a lymphocytic infiltrate that should not necessarily be in a thyroid gland. And it is obliterating normal thyroid tissue. So you could see areas here where there's really no thyroid follicles anymore. Or here, these are all lymphocytes and other autoimmune-related cells that are destroying what was supposed to be normal, healthy thyroid follicular architecture. And because there's a destruction of normal, healthy thyroid follicular architecture, the thyroid gland can no longer make thyroxine and T3. It's the most common cause. It's seen more commonly in women, which is not uncommon in the autoimmune world. There is a positive antibody prevalence. That TPO antibody I talked about is sort of what we use as a marker for Hashimoto's hypothyroidism. The reason it's not specific for hypothyroidism, though, is that there is a prevalence of this antibody in the general population. Roughly speaking, around 10% of the population of the United States may have this antibody, and the vast majority of those people are not actually going to develop hypothyroidism. So it's an autoimmune marker, but it doesn't actually mean hypothyroidism is present. The lymphocytic infiltrate is a mix of CD4 and CD8 T cells and B cells. There's a genetic component to this. There may be some type of environmental insult that happens later on in life that triggers the actual autoimmune reaction. There are other endocrine disorders associated with this. Type 1 diabetes, Addison's disease, vitiligo. We'll learn about polyglandular autoimmune syndromes when we talk about the adrenal. Hashimoto's antibodies are very common. These associated disorders are very uncommon. So what does hypothyroidism look like? What do patients present with when they have no functioning thyroid? So it's some pretty nonspecific symptoms. Tiredness, some weight gain, swelling, feeling cold all the time. That's an important one. All right. Thermoregulation drops. Proximal muscle weakness, there's a myopathy associated with hypothyroidism. There's actually, you can see muscle damage and an elevation of CPK and a lack of clearance of the muscle enzyme CPK, which you'll learn about more in musculoskeletal. The gut slows down. Remember that thyroid hormone is important for gut motility, so constipation. In its most severe case, you can have an ileus or a lack of peristalsis. Hoarseness of the voice, usually because there's a lack of clearance of things like glycosaminoglycans, and you get accumulated fluid in the vocal cords, so there's sort of a deepness and hoarseness of the voice. Slowed mentation, that's particularly something we see more in elderly patients who are at risk for that. And then you add hypothyroid. Irregular menses or lack of periods. What you actually see on physical exam, so dry skin and cold skin. Right? There's a lack of thermoregulation and diverted blood flow. Periorbital edema here, this is a buildup of glycosaminoglycans. A depressed affect, you can actually see peripheral vascular constriction and hypertension, a slowed heart rate, bradycardia, decreased myocardial contractility. Remember, thyroid hormone is a inotrope. So you get decreased contractility. You can actually get pericardial effusion, the same kind of edema that can get built up in the peripheral circulation, can build up around the heart. You can see here this patient is suffering from edema, tiredness, brittle nails, and hair. There's actually there used to be, we don't see it very much anymore, sort of a form of a cardiomyopathy associated with hypothyroidism in its more severe state. We don't see it because most people who have hypothyroidism, the disease is picked up quite early because we don't really screen for it, but it's an easy test to order, so we find abnormalities very easily. What do we see on labs? So you could see anemia because thyroid hormone is important for erythropoiesis. Hyponatremia, remember, you can't clear free water. There's free water retention. So in cases of hypothyroidism, you could see hyponatremia, free water excess relative to solute. Abnormalities in liver enzymes is very rare, but something that can be seen in hypothyroidism. The CK enzyme elevation I mentioned. And then not uncommonly, and Dr. Stein will talk about this tomorrow, you can get different forms of hyperlipidemia. Usually it's a mixed hyperlipidemia with high cholesterol and high triglycerides because you're not clearing these particles from the circulation. So those are your lab findings. If hypothyroidism is untreated, all of the signs and symptoms can continue to worsen. So you get worsening high cholesterol, worsening heart failure, worsening effusions, more severe anemia, neurologic abnormalities, and then this disorder, mixed edema coma. And mixed edema coma is the most severe form of hypothyroidism. And again, it is very rare. We usually see it mostly in people who are not taking their medications on a regular basis and then have some type of other insult. What are the features of mixed edema? Well, it is everything you see in hypothyroidism, but sort of a little bit more to the extreme. So decreased mental status, confusion, lethargy, coma, hypothermia, so low basal body temperature, 94 degrees when it should be 97. And then, as I mentioned before, hyponatremia, because you can't clear free water, bradycardia. Hypoglycemia can be seen, usually in severe states. Hypotension, so a drop in blood pressure. Again, that happens in very severe states. And then there usually is a precipitating illness. So what kind of precipitating illnesses may there be? The most common is infection, such as a pneumonia or urinary tract infection, but myocardial infarction can occur, stroke. Somebody who is hypothyroid and begins to take things, say, to help them sleep, or anti-anxiety pills, which are sedatives, or respiratory depressants, those drugs don't get cleared as quickly as in the normal euthyroid state. So hypothyroidism, when you see it, you have to be very careful about what medication somebody may be on until you can restore their thyroid function to a normal state. Because things that would otherwise get cleared rather quickly, like a sleeping pill at night or something for anxiety, they're going to hang around for a longer period of time, and patients may actually suffer from respiratory depression because of it. So how do we treat hypothyroidism? Well, we basically give back the hormone that the thyroid makes in its majority. Only it's called levothyroxine. It's a synthesized form of thyroid hormone. And this is the dose we use. You do not have to be responsible for doses. The one thing I do want you to think about, though, is if you have somebody who's a little bit older or has underlying heart disease and their cardiac contractility is suppressed and they're bradycardic, you don't want to give them full replacement of their thyroid hormone, because if you quickly upregulate their metabolism, you may actually induce arrhythmias, or you may induce ischemia. Cardiac ischemia means the muscle is asking for oxygen and nutrients that can't be delivered to it. So if you think about it, somebody in the hypothyroid state, everything is slowed down. And so you want to slowly build back up their thyroid hormone concentrations. And we do it sort of with low doses over a longer period of time rather than just quickly giving somebody full dose replacement, because that could actually induce cardiac problems. And I'll tell you the one sort of caveat to that. For younger patients, though, or somebody without any heart disease, if they're under 50, you can give them full dose replacement thyroid hormone, because we don't worry about that so much. T3 is not generally used as a replacement hormone. It has a short half-life. There's fluctuating levels. The physiology of replacing thyroid hormone is that if we continue to deliver T4 to the peripheral tissues, they will take the T4 and convert it to T3 and use it without having a need for T3. One thing that can be seen if you do give replacement with T3 is because of its activity, and it doesn't need to be converted to anything to be active, you may see an upregulation or hyperthyroidism associated with the drug. So if someone is taking T3, you want to measure their T4, and you have to measure their T3 and TSH concentrations a little bit more carefully. Some studies have shown that people may feel a little bit better with T3, but that's very controversial. And there's also the risk that giving T3 can upregulate cardiac arrhythmias and osteoporosis. So we give basically levothyroxine, not Synthroid. That is a specific name of a specific drug. It's levothyroxine that we give. Combinations are available. You'll hear about this as natural, Nature-Throid, Armour-Throid. These are natural formulations of thyroid hormone. They have some T4 and T3. They come from dried out thyroids of grazing animals. And there's a different T4, T3 concentration in grazing animals, who are usually grazing inland and don't get iodine supplementation, than we would expect to see the T4 and T3 concentration in humans. So although it's referred to as natural, it's not natural because the concentrations are different than what you would see in a normal human physiology. So we tend not to use it, but it's available. Once you start giving thyroid hormone replacement, after a couple of months, usually about 6 weeks, you need 5 to 6 half-lives. And levothyroxine has a half-life of 7 days. So after around 6 weeks, you're going to start to check your thyroid function test. When you see TFT, that's thyroid function test, it means free T4 and TSH. In primary hypothyroidism, where we expect TSH to be regulated, you want to see normal concentrations of free T4 and normal concentrations of TSH. In central hypothyroidism or secondary hypothyroidism, that TSH is not reliable anymore. So we really don't measure it. We just aim for the free T4 level to get somewhere in the middle normal range. So it's a little bit of a different treatment and follow-up paradigm, depending on what the cause of the underactive thyroid is. Now, mixed edema, as I mentioned, there was one corollary to using very high doses to treat patients with an underactive thyroid, and that's when you suspect mixed edema. Mixed edema is exquisitely rare but life-threatening. Probably the vast majority of mortality can be declined or decreased with great intensive care unit care, but there is this role for thyroid hormone replacement, and whether or not or how big your doses should be, you don't need to be concerned with doses. Just understand that in mixed edema coma, that's the one situation, because of its high mortality, where we actually give high doses of thyroid hormone replacement to try and quickly bring someone's thyroid concentrations up, because we're worried that if they have persistence of hypothyroidism, it's going to be a mortal event for them and they'll die. And that is the end of the first talk. So any questions, general questions, before we break? Yeah? How does hypothyroidism cause edema? So usually it's because you're not clearing things like glycosaminoglycans that sit in the periphery tissues. And so there's a buildup of fluid and water that's associated with the glycosaminoglycans and their tonicity in the periphery. Unless the main mechanism for a specific patient is related to an underlying cardiomyopathy, because then it's not forward flow. Okay, so we're going to take a 10-minute break. We're going to restart at 37-ish, and I'll be up here for questions if anybody has them.